Let's talk about another group of patients, non-clear cell carcinomas. Nizar, you did some studies in non-clear cell carcinoma. Do you want to talk about that?
Yes, I think this is a very challenging group of patients to treat. Unfortunately, the approved target agents that we have, the studies have all been conducted in patients with clear cell RCC. Except for the global ARCC trial with temsirolimus versus interferon versus the combination, where 20% of those patients had non-clear cell histologies. So, but there have been data all over the place with target agents in non-clear cell. Initial retrospective studies showed activity with sorafenib and sunitinib. Then, of course, that global ARCC trial I just mentioned, temsirolimus was superior to interferon in that 20% of the patients who had non-clear cell. So there was interest to test an mTOR inhibitor in non-clear cell. And there have been single-arm studies with sunitinib. I'm not aware of anyone that's published with pazopanib, although there is one that's being conducted by the Mayo Clinic, I believe. But with sunitinib, there have been at least several single-arm studies in non-clear cell. One Korean study was positive in the sense it had PFS in the 6 months range with sunitinib, and the response rate was in the 30%, similar to what we see with clear cell. But our single-arm study with sunitinib that we published 3 years ago in European Urology in 57 patients, we reported 5% response rate and a median PFS of 2.7 months. So we were not impressed with sunitinib in metastatic non-clear cell. But that study was a mixture of patients with good risk, intermediate risk, and some were poor risk. And there were 8 patients who were previously treated. But we decided to conduct a randomized trial looking at the mTOR, and we used everolimus in the ESPN trial. So the ESPN was everolimus versus sunitinib, prospective evaluation, non-clear cell RCC. So, the Duke team, led by Andy Armstrong, and also designed a very, very similar trial, the Aspen Trial. And those 2 trials basically compared everolimus and sunitinib. And the primary endpoint for both was progression-free survival in the first line. The differences between ESPN and Aspen is that in ESPN, our trial, we allowed patients after progression with the first-line agent to cross over. Aspen did not allow crossover. Aspen recruited patients with papillary, chromophobe, and unclassified. We recruited the same, and we added another cohort of patients with clear cell RCC who had more than 20% sarcomatoid features in their primary tumor. But the results of both these trials were very similar. And I'll point some differences in the results, but very similar. Our trial, I presented that at ASCO 2014, and Andy presented the Aspen results this past June at ASCO 2015. Sunitinib was found to be superior to everolimus, or at least everolimus was not found to be superior as the premise or the hypothesis was for both trials. So the data was better with sunitinib, but both agents showed very modest activity, therefore reinforcing the idea that we really need to have more effective therapies for these subgroups of patients. It's a diverse group of patients with different biology than RCC clear cell, where it's driven by VHL, and therefore it's a VEGF disease, clear cell. The non-clear cell are not necessarily so, and they have their own different, genetic and genomic alterations. So we really need to continue the research to study as well as develop therapies that are more effective for the non-clear cell. But I'll come to the differences between the 2 trials. With Aspen, they found that chromophobe patients did better with everolimus than they did with sunitinib, and patients who had poor risk disease in the Aspen trial benefited better with everolimus. Now, we did not find everolimus better than sunitinib in chromophobe. In fact, our 2 trials, the first one, the single-arm study we published, and the ESPN trials, both showed efficacy of sunitinib in chromophobe. The ESPN trial did not had very few, only 2 patients who had poor risk, so I can't comment on that. So the way I treat my patients with non-clear cell histologies, I enroll them on a clinical trial. We really need to enroll them on clinical trials.
Can I just add?
Yeah.
The problem with this area, and you've eloquently described it, is that we're not dealing with activity in one cancer type. We're dealing with cancer, with activity in a whole range of different cancer types. And because of the relative rarity, the studies are never large enough to be able to do a powered subset analysis and really get an answer about whether or not you can identify a group of cancers that has benefit from one drug as opposed to the other. So the situation is that we're dealing with effectively a whole series of niche cancers, rare cancers. Now there are ways to do rare cancer studies, but they're not generally best done in the way that we've done them so far, which is take a whole series of them and you have 50 patients, either randomized or non-randomized. You don't learn enough from that, and so there are international rare cancer programs in a whole variety of different types where people work more collaboratively, where you generate databases and registries, and you pool data and get some sort of higher powered insight into what's going on.
I think we're getting better at that because now there's a single arm savolitinib study that solely looked at papillary renal cell carcinoma, and now there's a intergroup study comparing different MET inhibitors for just papillary. So I think we're starting to get there, starting to get the momentum going, studying single, more homogeneous
It's certainly possible with papillary because you've probably just about got enough patients to do that.
Right.
But with the other ones, it becomes even more difficult.
But even there, though, you have papillary type 1, papillary type 2, not all papillaries. Even papillary type 2 is different subtypes, as we know molecularly now.
Papillary type 1 is c-MET predominantly, and the c-MET inhibitors are doing very well in papillary type 1. So
But
I
maybe
think
not type 2.
not type 2 is different. Type 2 is genetically different.
That again is a challenge in all oncology. We are starting to genetically study patients and tumors and finding small number of patients with specific abnormalities. And that's going to be, like you said, a very big challenge for all of us in how we're going to be able to get enough patients in order to actually conduct the appropriate trials.
Let's move on to second-line therapy now.
Can I just quickly add something which I think is extremely important, and you pointed it out. I think that the more drugs we're getting, the more drugs we have, I think it's really critically important that we as doctors learn from our patients and that we're really aware of how they feel at home, how their life is. And I think the COMPASS was a very important trial, and PISCES was a unique trial. It's not the only trial in cancer to investigate patient preference and on top of that doctor's preference. But I really think that we should do more investigations into that area because it's so important how the life of the patient is. And I was a bit surprised because years before, in 2012, there was the JCO publication of pazopanib as a phase 3 trial. But we already knew from phase 1 data that pazopanib is a very easy drug for patients. So I tended to use it. I started to use it for the elderly, for the crumble patients, and I'm still very happy even before we had the COMPASS data and the PISCES data. But it's something which is important.